we will proceed to metaplastic changes, which is apocrine metaplasia, columnar cell changes, clear cell metaplasia, and squamous cell metaplasia. The apocrine metaplasia is very common in fibrocystic changes. This is the classic example of apocrine metaplasia. And again, any metaplasia can become hyperplastic, it can become DCIS, and carcinoma can develop. But in apocrine metaplasia, 3 times nuclear enlargement is very, very important. I will go to the high power. This is apocrine metaplasia. The nuclei will have prominent nucleoli. But look at the nuclei. All the nuclei are of same size and shape. Can we call it carcinoma? Usually the nucleoli become prominent in carcinoma. But for the criteria for apocrine carcinoma, nuclear variation should be there. Smallest nuclei and the largest nuclei should have a difference of 3 times. Whereas here, they are all having the same nuclear size and shape. So this is benign. Columnar cell lesions also very important condition, which is not diagnosed that much in India. And previously we used to call blunt duct adenosis, but now WHO banned this terminology and it is known as columnar cell changes, okay, or columnar cell lesions. They are cystically dilated glands lined by tall columnar cells, okay, and now it is classified into columnar cell change without atypia, CCC, columnar cell change with the atypia. And this columnar cell change with the atypia is also known as flat epithelial atypia. And the columnar cells may undergo hyperplasia without atypia or with the atypia. Okay, so no hyperplasia without atypia and with the atypia, hyperplasia without atypia and with the atypia. There are 4 types. So what will you see here? In columnar cell change, I told you normally it is only up to 2 cells. When you see more than 2 cells, it is hyperplasia. Okay, and here the cells look more columnar. Okay, usually the epithelial cells are cuboidal, whereas when you see tall columnar cells, you call it as columnar cell change. Okay, and apical snouts are very prominent in columnar cell hyperplasia and with the atypia. Calcification is very common in hyperplasia and with the atypia. Okay, so nucleus, it's ovoid or long, whereas in with the atypia lesions, it will be round with prominent nucleoli. Low grade dysplasia is present in atypical conditions. And how do you manage whenever they done core biopsy or excision, when you see columnar cell changes or columnar cell hyperplasia, just follow up, nothing else. Whereas when there is atypia, you have to excise the lesion. Okay, any atypia you have to excise, whether it is columnar atypia or atypical atypical ductal hyperplasia or atypical lobular hyperplasia. The minute you hear the word atypical, you have to excise. This is a nice example, columnar cell changes, apocrine snouts with mild atypia. You can see multi-layering, more than 2 layers of cells. So it is a hyperplastic. See here, 1, 2, 3, 4, 5 layers. Okay, more than 2 is hyperplasia, and it shows some variation in nuclear size and shape. That's why it is atypia. Okay, so this is a best example of columnar cell change, columnar cell hyperplasia with the atypia. This columnar cell change forms a part of Rosen triad. Rosen triad is nothing but columnar cell lesions, lobular neoplasia, and tubular carcinoma. Okay, here you can see this is the nice H&E section. Okay, these are columnar cell changes. This is lobular hyperplasia or lobular carcinoma in situ, and this is a tubular carcinoma. When you do E-cadherin, the ductal epithelial lesions are positive, whereas the lobular lesions are negative. You all know the cadherin is lost in lobular lesion. And when you do P63, the tubular carcinoma won't have the nucleus, whereas the benign background glands may have the brown nuclear staining of the myoepithelial cells, whereas the tubular carcinoma won't have. So remember the Rosen triad, they may ask you in the exam, which is nothing but columnar cell lesion, lobular neoplasia, and tubular carcinoma. Coming to ductal epithelial hyperplasia, criteria: more than 2 layers of heterogeneous cells. This heterogeneous, 2 things you have to stress here. More than 2 heterogeneous cells. There will be ductal, lobular, myoepithelial. Okay, it is a mixture of cells, heterogeneous cells. And when do you call mild? Strict criteria are there. Lumen is present and it is lined up to 4 cells. Moderate, when the bridging of the lumen by the proliferating cell, that means more than 4 layers of cells causing the bridging of the lumen. We will see the pictures now. Severe, there is obliteration of the lumen by the hyperplastic cells. Okay, so this is all the lumen is present, but the epithelial cells are more than 2. So it is hyperplasia, but the lumen is present, so it is mild. Here what happens? The cells are forming bridges in the lumen. Okay, they are becoming more hyperplastic and they form bridges. Here you can see the bridges, nice bridges. Okay, so this is moderate. And here peripherally lumen is present, but in the central portion there is no lumen. So this is florid. I know there is some peripheral lumen, but in the center there is no prominent lumen. Here you see the lumen here. So this is mild, moderate, and severe ductal epithelial hyperplasia. And they will have associated calcifications. Okay, so in this picture you can see mild, moderate, and severe. Okay, you see everything. Okay, and once you see more than mild and moderate, when you see severe, you call it florid ductal epithelial hyperplasia. The importance is we should not misdiagnose this for DCIS. Okay, and that's why the ductal epithelial hyperplasia is very, very important. And all the another thing you have to remember, is there any high power in this one? There is a heterogeneous population. See the vacuolated cells. These are the myoepithelial cells. Okay, the myoepithelial cells are sent in the center as well as in the periphery. That concept is very, very important. Any benign condition, it is a heterogeneous population of tumor cells. So here also you can see the heterogeneous population, and see the myoepithelial cell. This is a nice picture, smooth muscle actin. Okay, it's a myoepithelial. Myo component take the smooth muscle actin. See how much myoepithelial cells are there. If it is DCIS, it should not have myoepithelial cells. And another feature is spindling of the tumor cells and the apocrine metaplasia. These are all associated with ductal epithelial hyperplasia, not with DCIS. So now we have seen the criteria for ductal epithelial hyperplasia. Now we will go and see what is DCIS. It is a proliferative breast lesion with the ATP and calcification, monomorphic proliferation. Okay, whereas that is heterogeneous proliferation, DEH. Okay, and the nuclei are graded into 1 to 3. 1 is mild atypia, 3 is severe atypia, and 2 is in between. Okay, these are the pictures: mild atypia, severe atypia, 2 is in between 1 and 2. That's why I don't like the 3-tier system. No criteria. Grade 2, intermediate, intermediate, intermediate. It's sometimes difficult. Okay, so when to call grade 1 and grade 2. That's why what they have done is, now they are going, this is a picture to show you high power, grade 1, grade 2, and grade 3. Grade 1 is easy, grade 3 is easy, grade 2 you push it to either grade 1 or grade 3. That's why now they are going for 2-tier system, low grade and high grade. And when it is high grade, with necrosis and without necrosis. Here you can see with necrosis, here you can see without necrosis. That brings to what are the types of DCIS. The typing depends upon the architecture and the cell type. Okay, architecturally it can be flat, it can be cystic, it can be mucinous, it can be papillary, cribriform, solid, or with comedonecrosis. But when you pay attention to the individual cells, they can be apocrine cell, there can be clear cell, they can be spindle cell, there can be signet cell, there can be small cell. These are all the DCIS types depending upon the cell type. Let us see the pictures. Here it is cystic spaces. In the low power looks like a benign, but when you go to high power, they are lined by monomorphic population of cytologically abnormal cells. So this is cystic DCIS. This is clinging DCIS. In cystic DCIS, it is a low-grade cytological atypia, whereas in clinging DCIS, it is single layer of cells with a high-grade dysplasia. Okay, this is clinging type. This is mucinous DCIS. This is papillary DCIS. And this is a solid DCIS. And here, this part and this part, they are cribriform DCIS. Okay, and see the luminal spaces. They are more or less the same, uniformly distributed. Okay. So that is very, very important, and we will see it in the table. And this is the classic example of comedonecrosis. And coming to the cell types, this is apocrine DCIS, clear cell DCIS, spindle cell DCIS, signet cell DCIS, and small cell DCIS. Sometimes it may look like lobular carcinoma, but you do E-cadavering, The small cell DCIS will be positive for E cadherin, whereas LCIS will be negative for E cadherin. Sorry. That brings this table DEH and DCIS. How will you differentiate? Again, low power spaces, irregular, non-uniform cells, overlapping. This is another important feature. These are polymorphic cells and overlapping of these cells. Breast is the only organ where overlapping is benign, whereas in any other organ, the overlapping is malignant. What happens in breast? The adhesion molecules are becoming less in number towards malignancy. So when they become malignant, the individual cells will have no overlapping and they will have a distinct cell border. So when you see distinct cell border without overlapping in breast, it has to be either DCIS or carcinoma. And in the low power, when you see hemorrhage and necrosis, it's mainly DCIS, and periductal stromal changes in DCIS. Okay, so this is irregular spaces and they are compressed in the periphery, whereas in DCIS, they are regular in size, shape, and distribution. The cells are overlapping if you see it in high power, and heterologous. Please remember, polymorphic, whereas here it is monomorphic. Coming to the high power, again, admixed epithelial and myoepithelial cells, metaplasia, spindling of spindle cells, and another important thing, I will show it to you in the picture. Whenever you see bridges, see this is a bridge. Whenever you see bridge, look at the axis of the cells that are in the bridge. Okay, in benign conditions, they run along the bridge. Okay, so that's why it is parallel. Okay, here you can see long axis of the nuclei parallel to the intraglandular bridges, whereas in DCIS, they will stand. Okay, they will stand here. They are perpendicular. Okay, that's why it is known as Roman bridges, perpendicular. Okay, so that is a very important feature you have to remember. And when you do IHC, the DEH is a polymorphic population. So you see the myoepithelial cells in the periphery as well as in the center. Whereas in DCIS, you never see myoepithelial cell in the center. They always look at the periphery, present in the periphery. Another very important thing, estrogen receptor. When you do estrogen receptor, it is heterogeneous in ductal epithelial hyperplasia because it has epithelial and myoepithelial cells. Whereas in DCIS, it's only epithelial cells, so it is more homogeneous. Okay, so P63 and ER may help you to differentiate DEH and DCIS. So you may be wondering why I talked about DEH and then went into DCIS without talking about atypical ductal hyperplasia. Because atypical ductal hyperplasia is nothing but DCIS. It is DCIS, but that DCIS is confined within the two ducts or up to 2 millimeters. So when they ask what is atypical ductal hyperplasia, and when you answer it is mildly atypical, it is present this one, that one, you are wrong. When somebody asks what is ADH, you have to first word is it is DCIS. And it is a quantitative diagnosis. When the DCIS is involving less than 2 ducts or less than 2 millimeter, then we call it as ADH. That's why I want to see the difference between DEH and DCIS. So ADH is nothing but DCIS confined to 2 ducts. Okay, this is only one duct showing DCIS. This is only one duct showing DCIS in core biopsy. So can you diagnose ADH in core biopsy? No, we don't know what is happening in the other organs. Okay, so you mention in the core biopsy, if you see this, you say cribriform DCIS involving only one duct. It may represent ADH, but excision of the lesion is suggested to diagnose DCIS. Coming to papillary neoplasms, this is again another spectrum: papilloma, atypical papilloma, carcinoma in papilloma, papillary carcinoma, which can be invasive or non-invasive. Even though it looks difficult, this is the concept slide you have to remember. Okay, as I told you, the benign epithelium will have myoepithelial. These yellow dots are myoepithelial cells. Myoepithelial cells are in the periphery as well as in the center of the lesion, benign papilloma. Whenever you don't see myoepithelial cell, you have to quantitate. If no myoepithelial cells are seen, the myoepithelial cells are seen only in the periphery, not in the center, then it is DCIS, and because of the papillary pattern, this is papillary DCIS. But look at here, when the myoepithelial cells are absent only in part of the papilloma, okay, for example here probably 1/3 of the papilloma doesn't show myoepithelial cell, then it will become ADH involving the papilloma or DCIS involving papilloma when it is more than 1/3 of the area. But what you have to remember is, in ADH and DCIS involving a papilloma, myoepithelial cells are seen in the center in part of the lesion, whereas when you call papillary DCIS, myoepithelial cells are not seen in the center. Then when do you call encapsulated papillary carcinoma, myoepithelial cells are not seen in the periphery as well as in the center. So this is a classic image cartoon that tells a lot of points. Myoepithelial cells in the center or in the periphery. They are not present in a papillary lesion, not present either in the center or in the periphery. It is encapsulated papillary carcinoma. When the myoepithelial cells are present only in the periphery, then it is papillary DCIS. Myoepithelials are present in the center and periphery, but not throughout the center, then it will become ADH and DCIS depending upon how much area is not showing myoepithelial cell. In a case of papilloma, you have to see the myoepithelial cells in the center as well as in the periphery. I kindly request all of you to take a picture of this. This understanding is very, very important in papillary lesions. So how will you approach? If you put a flow chart in a papillary breast lesion, first look for fibrovascular core. When it is present, look for epithelial proliferation. When there is no epithelial proliferation or it shows only ductal epithelial hyperplasia, okay, then you look for sclerosis. When the sclerosis is not there, it is papilloma. When the sclerosis is there, it is sclerosing papilloma. Okay, so fibrovascular core, epithelial proliferation up to DEH with or without sclerosis. Now you come epithelial cell proliferation looks like low grade DCIS. Then you see how much of the papilloma is showing that area. Low grade DCIS means no myoepithelial cells present in that area. If it is less than 1/3, then it is atypical papilloma. When the DCIS is there and it is occupying 30 to 1/3 to 90%, then it is carcinoma in papilloma or DCIS in papilloma. And when it is more than 90%, look for invasion, and when there is no invasion, it is non-invasive papillary carcinoma. When the invasion is present, it is invasive papillary carcinoma. It is for low-grade DCIS. So to call it atypical papilloma or carcinoma in papilloma, papillary DCIS, it has to be low-grade DCIS. When you see features like high-grade DCIS in a papilloma, you have to look whether it is less than 90%. When it is less than 90%, high-grade DCIS, it is carcinoma in papilloma. If it is more than 90%, then you have to look for invasion. When there is no invasion, it is non-invasive. When there is invasion, it is invasive. When the fibrovascular core is not present, you have to, but that papillary pattern is present, no fibrovascular core. You have to think of micropapillary lesion, solid papillary lesion, or non-papillary lesions. I kindly request all of you to take a snap of this and keep it in your working desk. And whenever you see papillary lesion, you try to answer these questions and get the correct diagnosis. There is another new entity in the WHO which is called tall cell carcinoma with reverse polarity. You all remember the tall cell papillary carcinoma. When you see tall cell papillary carcinoma in the breast, it is known as tall cell carcinoma with reverse polarity, because this is the basement membrane and you can see the myoepithelial cells in the periphery, but the nuclei are staying away from the basement membrane. Okay, so that's why it is called reverse polarity. And the mutational changes happens in IDH2, and this is the immunohistochemical stain for IDH2. When you do see a tall cell papillary carcinoma like lesion in breast, do IHC and prove it as tall cell carcinoma with reverse polarity with IDH. So now we are shifting gears and coming to lobular neoplasia. Lobular neoplasia is mainly divided into atypical lobular hyperplasia and lobular carcinoma in situ. There is no lobular hyperplasia. Okay, there are only two lining, and whenever it is more than two layers of lining, we have to call it atypical lobular hyperplasia. Okay, and when it involves less than 50% of the acini, then it is atypical. When it involves more than 50% or usually all the acini with no pattern lumen, then it is called LCIS. Okay, so this is the example. See, the lobular pattern is maintained, but the lobules are showing individual acini are showing more number of cells, but it is not involving all the lobules. So this is atypical lobular hyperplasia. Okay, this is again atypical lobular hyperplasia, whereas here all the lobules are distended with the cells, and these cells are very uniform cells and occupying more than 50% of the acini, then it is LCIS. So 50% or more. If it is less than 50%, atypical lobular hyperplasia. If it is more than 50%, it is LCIS. And LCIS, there are many types: classic, pleomorphic. Okay, classic is made up of uniform cells, small, round, discourse. They look like a bag of marbles, or like here bottle of marbles. Okay, very nicely seen. Uniform cells, small blue cells. Okay, so they are divided again into two types. Type A is small, completely bland cells, whereas in type 2 some variation in nucleus. So this is type A, LCIS. And pleomorphic, they start showing pleomorphism, and some rhabdoid cells will be there. They are larger cells with irregular nuclei, but these are very uncommon. The most common thing is bag of marble appearance in LCIS. Okay, so this is the classic solid type, and this is clear cell type and signet cell type. And in the pleomorphic type, you see rhabdoid cells. Okay, pleomorphic type. These are all the classification of LCIS. How will you differentiate DCIS and LCIS? In the low power, DCIS involve the ducts. There is lumen formation with the cellular cohesion and necrosis, whereas they are absent in LCIS. Okay, here it is a classic example of DCIS involving the ducts, whereas here the classic example of LCIS, classic type. Okay, see, this is a lobule. All the acini in the lobule are dilated. No normal lumen is seen, whereas here you can see the lumen in DCIS. In LCIS, you never see the lumen. Okay, coming to high power, yes, this pleomorphism, depending upon the grade, this is grade 1, grade 2, grade 3, pleomorphism will be there in DCIS, whereas LCIS is usually low grade other than pleomorphic LCIS. Okay, pagetoid spread is present in LCIS. What is the pagetoid spread? These LCIS glands coming into the ducts like a paget cells. Okay, and the acini here irregular or partially involved, whereas in LCIS completely involved. You cannot differentiate normal acini here. Okay, and this is the pagetoid spread into the major duct. And when you do E-cadherin, all the pagetoid cells, they are the lobular carcinoma in situ cells. They will be negative for E-cadherin, whereas the attenuated ductal epithelial cells will be positive for E-cadherin. And we have a specific high molecular weight cytokeratin CK903 that is positive in LCIS, whereas E-cadherin will be negative in LCIS, whereas E-cadherin will be positive in DCIS. Okay, so the another DD is cancerization of lobules. DCIS can come into lobules. So how will you differentiate DCIS in the lobules with the LCIS? Okay, here in DCIS, this is like tumor cells coming in the already formed road. So the lobular architecture is retained, and the perilobular stroma will have desmoplasia. Whereas in LCIS, the lobular, I will show the picture so that you will remember. You can here it is the DCIS involving the lobules. That lobular pattern is maintained, and you see the malignant cells displacing the lobular acinar cells. Whereas here, and it is not involving all the acini. Okay, you can see some peripherally placed acini which are not involved. Whereas in LCIS, all the acini are involved with more uniform cells. This is the high power view showing the cytological ATPI in DCIS, and they are more monomorphic in LCIS. And I already showed the immunohistochemistry. E cadherin will be positive in DCIS, whereas CK903 will be positive in LCIS. Another interesting thing we have to remember when we are seeing low-grade lesion is collagenous pullosis. The DD is adenine cystic carcinoma and the cribriform carcinoma. In collagenous pullosis, you see the eosinophilic material. Okay, so in it may look like adenine cystic carcinoma, but when you do Ki67, the adenine cystic carcinoma will be highly positive, whereas collagenous pullosis will have very low Ki because this is a benign condition. Okay, I will just skip this slide because of the time. Mucinous lesions of breast, another important thing. Whenever you see mucin in any organ, you have to see whether it is extracellular mucin, intracellular mucin, or intra and extracellular mucin, because the differential diagnosis depends upon that. When you see extracellular mucin only, you have to think of mucinous cyst, mucocele-like lesion, mucinous DCIS, mucinous carcinoma, and metastatic carcinoma. When you see intracellular mucin, signet cell carcinoma, mucoepidermoid, and metastatic carcinoma. When you see both intra and extracellular mucin, it is secretory carcinoma, adenine cystic carcinoma, and metastatic carcinoma. All of you, I want to take all of you to take a snap of it, because this is the nice classification of the mucinous lesions of the breast. In mucinous carcinoma, there are two types. Type A is hypocellular, pools of mucin with the floating cells, whereas type B is hypercellular. Why you have to know that? Type B is usually positive for neuroendocrine markers, so they think it is going into neuroendocrine differentiation. It's very difficult to diagnose in the core biopsy because mucinous cyst and mucinous DCIS, it's very difficult. So whenever you see mucinous material in the core biopsy, you have to go for excision for a definitive diagnosis. I don't want you to miss any mucinous carcinoma by seeing only mucin in the core biopsy. This is another nice case we had, which is FNAC, we called it mucinous neoplasm, and they excised the lesion. It shows grossly characteristic multilobulated cystic structures with filled with mucin. So this is like mucocele, but it is not mucocele. It is having ductal epithelial hyperplasia and DCIS. That's why it is called mucocele-like lesion. Okay. So mucinous cyst, only cyst lined by benign mucinous, and mucocele-like lesion, hyperplastic mucinous up to DCIS, and in mucinous carcinoma, pools of mucin with invasion. This is secretory carcinoma that has most intra and extracellular mucin, mucoepidermoid carcinoma, adenine cystic carcinoma with a characteristic cribriform pattern, and signet cell carcinoma, predominantly intracellular mucin. Okay, this is a classic mucinous carcinoma. It has a classic picture. It looks like ice apple. நம்ம தமிழ்ல நொங்குன்னு சொல்லுவோம் இல்லையா? It will look like nongu. Nongu means ice apple, and you have to think of mucinous carcinoma and cartilaginous tumors. This is classic for cartilaginous tumors also. But microscopically, there are two types. Remember, I told this is hypocellular variant type A, hypercellular variant type B, which will be positive for neuroendocrine markers. So we are done with the DCIS, mucinous lesions, ADH or DEH. Now we are going to carcinoma. And microinvasive carcinoma, invasion less than 1 millimeter. Okay, so these are invasion less than 1 millimeter. That's the differential criteria you have to use, less than 1 millimeter. And you have to make sure it is, when you see invasion, whether it is true invasion or pseudo invasion. What do you mean by pseudo invasion? When you do FNAC, even DCIS, that FNAC tract, some cells may try to escape. Okay, that is known as pseudo invasion. So you look for hemorrhage, fibrin or blood clot, hemocellulin ladder macrophages, punctured ducts, displaced cells, granulation tissue, and fibrosis to diagnose pseudo invasion. This happens usually after a core biopsy. Okay, and pseudo invasion can have a lot of giant cells, and doing a cytokeratin stain will help you. These are all the micro-invasive cancer cells. The last end of the spectrum is invasive carcinoma, and the invasion should be more than 1 millimeter. And the mainly invasive carcinoma previously typed into ductal, lobular, and special types. But now this WHO is saying there is no ductal epithelial cells because most of the tumors are arising from ductal-lobular unit. So they want to call it as infiltrating breast carcinoma, no special type, okay, rather than ductal. Coming to immunohistochemistry, as I told you, luminal cells and myoepithelial cells, they are having difference. Luminal cells, low molecular weight cytokeratin, myoepithelial cells, high molecular weight cytokeratin, but more importantly, P63 or P40. I love the nuclear markers. Okay, this is a SMA. Okay, see the cytoplasm is staining, whereas here the nuclear marker, myoepithelial cells, they are very nicely seen. So go for P63 or P40. In the breast lesions, immunohistochemistry, where it is used, first, there are some markers that are useless in breast. They are the breast specific markers: mammoglobin, gross cystic disease fluid protein, GATA3, SOX10. They are positive in breast cells in benign, hyperplastic, DCIS, as well as in invasive carcinoma. Where they help in the diagnosis of metastatic breast carcinoma outside the breast, because these are breast specific markers, and you have to remember 90% or 95% of immunohistochemical markers are very good for diagnosing the cell of origin, whether it is breast or lung. But they are not saying in the breast it is benign or malignant. There is no specific marker to differentiate benign and malignant. So these markers are useful only in metastatic setup. Whereas we have very difficult situation in breast, for example, complex radial scar versus malignant, DEH or DCIS. These are the conditions where we need immunohistochemistry, and we can group the conditions, okay, benign versus malignant, DEH with the DCIS or DCIS with the microinvasion, DCIS with the LCIS, and what are the markers that are helpful in prognostic and theranostic view and in the sentinel lymph nodes. Benign versus malignant, you have to use these markers, ERPR, P63 or P40, and there is a specific marker which I have not used. It is known as ADH5. I will show you atypical ductal hyperplasia, and they use 5 markers together, okay, and calpone. But the main markers I have practical usage is ERPR and P40. DCIS or LCIS, E-cadherin and CK903. Prognostic and theranostic markers, you know, ERPR, HER2/neu, and PD-L1 and PD-1 and PD-L1. And sentinel lymph nodes, you are looking for miniature of the tumor cells that are in the sentinel lymph nodes. So you use pan-CK or AE1, AE3. I request all of you to take a picture of this. This is the immunohistochemistry in the breast lesions. See nicely here. This is tubular carcinoma in the center, no myoepithelial cell. Whereas in the periphery, some normal breast tissue or hyperplastic breast tissue is there, which is nicely showing P63 or P40. ERPR, heterogeneous, spotty positivity, benign. Homologous, strong nuclear positivity, malignant. DCIS, when there is no invasion. When there is invasion, it is carcinoma. ADH immunohistochemistry is the one where they use cytokeratin, low molecular weight cytokeratin, high molecular weight cytokeratin, and the P63. Okay, and here you can see this is a DCIS. You see the myoepithelial cells, P63 taking up the color, and the epithelial cells in ADH will be uniformly positive for luminal cytokeratin 7 and 18, which are low molecular weight. Okay, but I have not used this marker. Coming to ERPR, you know ERPR is a nuclear marker. HER2/neu is a cytoplasmic membrane markers, and HER2/neu it is 0 or 1 plus when it is less than 10%, 2 or 3 when it is more than 10% with a complete or incomplete membranous staining. 3 is considered as positive, 0 and 1 are negative, 2 is equivocal. Okay, you have to do fish when you see 2 plus in the IHC of the HER2/neu. And I just want to briefly touch the molecular classification of breast cancer, which is IHC based. It is subtyped into luminal A, luminal B, high Ki, and low PR, luminal with HER2, only HER2, and triple negative. And the triple negative is divided into basal-like and non-classified. Okay. To type this, you have to do these markers: ER, PR, HER2/neu, Ki67, CK5, and EGFR. CK5 and EGFR will help to differentiate triple negative into really basal-like breast carcinoma or non-classified breast carcinoma, because these are all the markers for the basal cells. So basal-like carcinoma should be positive. Okay. When do you call non-classified basal cell carcinoma? All markers are negative in a cancer. Okay. So which is usually triple negative, but we added 2 more markers. HER2, when do you call HER2? Only when HER2 is positive, all others are negative. And when do you call luminal A, ERPR positive? Low Ki67. When do you call luminal B, Ki67 more than 14%, fall under this category, and when the PR is more than 20%. And when the PR is less than 20%, you call it luminal B, PR less than 20%. And when HER2 neu is positive along with the luminal and the PR, it is called as HER2 PR positive. And when ER is positive and PR is negative, we call it HER2 PR negative. Okay. All of you please take a snap of this. This is the molecular classification, because in our country we cannot do NGS because they are so costly, but depending upon the immunohistochemistry, we can tell the clinicians what treatment they can give. This is one of the famous university questions. Please take note of it. Sentinel node, see, it's very difficult to identify the tumor cells, okay, especially in lobular carcinoma. But when you do pancytokeratin or AE13, you can pick up this much of cells. That's why we have to look for these cells. And PD1 and PDL1, you have to remember, and as I told you, whenever the lymphocytes are more with the tumor cell, this is a medullary variant of infiltrating breast carcinoma. You do PDL1 Ventana assay, and you see the number of cells. Okay, here it is clearly given: immune cell score, percentage of tumor area occupied by PDL1 positive immune cell. We are not looking for PDL1 in tumor cells. We are looking for PDL1 staining in lymphocytes. And when the lymphocytes are positive more than 1%, we call it as positive. Okay. Here it is the immune cell score is like 20 to 25%. So this is PDL1 positive. So they will respond to anti-PDL1 treatment. Finally, molecular changes. These are all the 6 events or 6 lesions in the breast that are definitely having the molecular change. Lobular carcinoma, cadherin mutation. CDH1 is nothing but cadherin mutation. Adenoid cystic carcinoma, MOIB. We have immunohistochemical IHC marker. Secretory carcinoma, NTRAC. Okay, we have PanTrac IHC for that. Mucoepidermoid carcinoma, MAML2 and CRTC1. We have IHC marker for MAML2. Pleomorphic adenoma, PLAG1. This is pleomorphic adenoma gene 1. Okay, very easy. If they mark all the markers like this, for example, mucoepidermoid MGA1, mucoepidermoid associated marker. No need to memorize them. Tall cell carcinoma, I already showed you IDH2 R172 172 mutation. Okay, please take a snap of this. These are all the proven molecular changes. Lot of molecular changes are happening in breast, but these are proven. Okay, and they help in the diagnosis, and they will help you in the deciding the treatment also. So to conclude, benign or malignant, go to low power, high power, and IHC. Architecture maintained, varying sizes and shapes of the penetration in the periphery, compressed, cells are arranged polymorphic pattern, no necrosis, they are all benign. Just opposite is malignant. Take a snap of this. Coming to high power, metaplastic cells, long axis parallel, dysplasia absent, atypical mitosis absent, benign. So you use a set of criteria, follow the triple test, and whenever there is a problem, give a call to the clinician. And this final one, when you have to excise the lesion, when you see it in core biopsy, sclerotic lesions, papillary lesions, mucinous lesions, ADH and ALH, DCIS, LCIS, microinvasive carcinoma. When you have invasive carcinoma high stage, before treating chemotherapy or post chemotherapy, to know the response, you have to excise. You should not do only core biopsy. This you have to remember. Okay, correlation, cytology, and subsequent surgery.